exam pattern, let us begin the year. Okay. How will you examine the external auditory canal? What are the things you need to examine the external auditory canal? If you tell the word otoscope, you will be failed. You are supposed to tell the basic things required for examining the ear. Never tell the word thought. Once again, if you tell the word thought side, then it carries a very bad impression of you. The idea behind examination the ear nose study is you have to make your both hands free. Okay. If you are using the thought slide, your one hand is occupied, engaged. So you use the light numbers. You have a proper light source. What are the different light sources? You need a proper light source. The பக்கத்து மூல பாத்தீங்கன்னா சிலதெல்லாம் வச்சிருப்பாங்க பாத்துட்டீங்களா? Transstander வச்சிருப்பாங்க பாத்தீங்களா? What are all the components of the bullseye exam? Light source from the bullseye lamp, light source is coming. That light is reflected by the mirror which we are wearing in the head. That's head mirror. And then this light gets focused over the patient's area of interest. Simple concept. Okay. This is depth. Okay. So, bullseye lamp is what the capacity of the bullseye lamp? It is 100 watts. 100 watts. Okay. And our lens is the lens. You all go and see that one. It's a biconvex lens. So, 100 watts bulb is biconvex lens. That is the light of the, it is falling over the head mirror. This is a mirror actually. What is this mirror? It is a concave mirror. In the concave mirror level, there is a nodule of the chin aperture. It is roughly 2 cm in diameter. Okay. So the examiner will be putting the head mirror. Okay. And the light will be falling over the concave mirror of the head mirror. And here, from here, this light will be focused in the exit. This focal length, so the focal length is roughly some 80 to 20 centimeters. That is the focal length of the this concave mirror. Okay. Under 20 centimeter distance, patient is the light focus on. So this is the small setup of a bullseye lamp. But nowadays, the bullseye lamp is not being used. The reason is it is space occupying. Okay. And next is we have got a better illuminating sources we have got. We have got the fiber optic light source. That is not used. But even now, many seniors still they are using the bullseye lamp in the OPD. That's the trick of this bullseye lamp. The lamp everything known, there is a light source, 100 watts bulb, biconvex lens, concave mirror, fuller diameter 2 cm, focal length roughly some 20 cm focal length. This is the bullseye. Now next question, what's the name? Rajalakshmi. Okay. From which place you are coming from? So, first question I have Vignesh Ketartha. How to exam external taken what you need is you need the proper light source. So that you can have a headlight, you can LED headlight use or else you can use the bullseye lamp and then Duke's headlight only. There will be a mirror, and the mirror lay on the bulb attached. Duke's headlight can be used. Now, how to examine the external? Wait this before you. Posterior superiorly. So, what you want now, want to straighten the canal. Make it simplify yourself. The concept is just like that you cannot examine the external canal. The external canal has to be straightened. That's very important. First you yeah. Sir, I will first straighten the canal. The examiner knows that you will know you have examined the patient very well. So I will straighten the external canal by pulling the pin now upwards, outwards, and laterally. The general concept. Upwards, outwards, laterally for now. You will be straightening the external canal. Then only you can see the entire external canal, because the shape of the external canal is S shape. Okay. Suppose you are not able to visualize the external canal clearly. Sometimes you can see a lot of hair walking the view. You can see only the hair. Some persons will be having more hair. What will you do? How will you examine? Hair எப்படி clear பண்ண முடியும் ப்ரோப்ல? The hair had to be displaced sideways. Yeah. This is the oral speculum. So these instruments will be, everyone will see now. Oral speculum. So if you keep the oral speculum, the hair will be displaced laterally, and the center portion within the canal, within the speculum, you can see what is actually the external canal. Sometimes you can see the bracts. Sometimes once the hairs are displaced laterally, directly you can see the hip and hip. That is the way to examine the external canal. You are seeing the bracts there. So now how will you proceed? Loosen the bracts. How will you loosen them? What is that? Secretions of cerebral glands. Then only cerebral glands. Sebaceous glands. And then epithelial crust will be there. It's a combination of the secretion of the sebaceous cerebral glands and epithelial debris. So you are seeing the wax and you want to loosen the wax. How to loosen the wax? Oil. You want to be very economical. So you are using oil. So you loosen paniyan. Yes. Now what will you do? How to remove the wax? Yeah. So this is Jobson Horns probe. So with the probe you can remove the wax. That can be removed either with the headlight. That is a must, basic. And sometimes it is better to remove the wax with the endoscopic guidance. Because if you use the endoscope, you can exactly know where to keep the probe. Unnecessary damage to the skin of the external canal can be prevented. So one is Jobson and Horns probe can be used. Good thing. Where nobody will get syringing can be done. But what is the contraindication for syringing? There should not be any perforation in the hip. If there is any perforation or there is any history of ear discharge, sometimes you can see the wax there. Beyond the wax, the patient might be having a perforation. You don't know that. Okay. So in this case, you should ask the patient whether there is any history of discharge. Or there is patients தெரியும் காதுல உங்களுக்கு ஓட்டை இருக்கா அப்படிங்கறது they will tell yes sir. So you should avoid doing so. Because if you do syringing, what happens, you will be making the dry air into wet air. You will be syringing all the contents into the middle ear and you will be discharged. make sure the TM is normal before doing syringing. So how to do syringing? What will you use for syringing? Okay, digital syringe. Okay, fine. Where will you give the direction of flow? Yeah, post to superior. That is the direction of flow. And then it will be completely washed out. Okay. And while syringing, the saline should be a sterile water, or it can be normal saline of the body temperature. It should be warm, or else caloric stimulation can occur. The patient can go for developed giddiness and all. Always the syringing water should be of the normal temperature, warm water. Any other way to record the max? One is by probing, you said, fine. Next is syringing. Third is the instrument, the wax scoop or instrument. Let me show you. Wax scoop. One is Johnson transported, or else you can use the wax scoop. Then any other method? It has become more wet. அப்படியே கொல கொல கொலன்னு மாறிடும். So suction. So suction is one method of doing the wax. By doing all these things, patient suddenly can have a syncope. Okay. They have leg syringing, or they are trying to remove with the wax scoop and all. What is the cause, or why the patient have syncope attack? That is, patient is telling is having giddiness and all. Yeah, it's a vagal. Yeah, it's a vagal stimulation. So especially you are touching the posterior wall of the external canal. Posterior wall of the external canal is supplied by which nerve? Or the auricular branch of vagus. Anterior is supplied by auricular temporal. So we have crossed the external canal. Okay, and we come to the tympanic system. So what are things you look in the tympanic system? What is the color? Pearly whites or otherly pearl. Mobility. How to check the mobility of the tympanic? Single slit mobility problem. Good. Then cone of. What is cone of light? Why it is seen in that area? You feel the TM is oriented in a straight away. It is obliquely placed. Why it is obliquely placed? Because the anterior wall of the canal is lengthier than the posterior canal. So it is obliquely placed. And it is making an angulation of how much degree with the external auditory canal? 55 degrees. So there is obliquely placed tympanic membrane, and the angulation it is forming with the external auditory canal. The two things make the light source to fall over the antero-inferior quadrant, and that light reflection is called as cone of light. Okay. Then what else can you see? Malleus. What are the parts of malleus? What is the shape of the malleus? Yes, good. Malleus is a hammer-shaped bone. Okay. Head, neck. Most important thing you will see that over the tympanic membrane. Head, neck, hand of malleus. Anterior process, lateral process. Yeah. These are the components of the malleus. So the TM will be first color visuals. still. Then the shape of the TM should tell. For the shape of the TM, oval shape. Okay. And then fill up the bone of light. Then you can see the handle of the malleus. Sometimes if the TM is very thin, then you can see the ossicular chain also you can see. We have seen. Suppose the patient had a discharge in the childhood. After that, it has healed. Either one thing is it can heal by only a thin TM will be there. Okay. The fibrous layer will be absent. That's called as a healed central perforation. So those cases, when you examine, you will think as if there is a perforation because it is so much very thinned out. And those cases, only those cases you have to fill the word otoscope. It needs a magnified examination. When you see the magnified view of the tympanic membrane with the endoscope or with the cerebral speculum, you can appreciate the very thin healed central perforation in only one layer. Epithelial layer, fibrous layer absent. So through that transparent tympanic membrane, you can see the ossicular chain. You can see the long process of fingers. You can see the equidostapedial joint. Okay. Sometimes the TM can be adherent, can be retracted. If it is retracted, then you can see the lateral process, anterior process to be very prominent. It's the lateral process, anterior process prominent. This TM can be sitting over the equidostapedial joint. That is a retracted TM. And then you can see the pars tensa, pars flaccida, which is separating the pars flaccida and pars tensa. Pars tensa and pars flaccida is separated by anterior posterior malleolar folds. The folds keel irukkiradhu the pars tensa, malleolar is the pars flaccida. Why this one is called pars tensa? Why the above is called pars flaccida? Middle fibrous layer is absent with the pars flaccida, or it is a deficiency. There are very minimal fibrous layer. Few fibers are there. There is two school of thoughts. One is there is the fibrous layer is absent. One thing. The next thing is very few fibers are there. But anyway, that fibrous layer makes a difference between the pars tensa and pars flaccida. So this pars flaccida, since the fibrous layer is absent, it is permitting the movement of the ossicles there. What is Shrapnel's membrane?
Pars flaccida.
What is notch of Revinus? Pars tensa will be attached to tympanic sulcus by the tympanic annulus. And the male it is deficient. That is called as notch of Revinus, where the pars flaccida will be attached. What are the structures behind the pars flaccida? Head of the malleus, neck of the malleus, then body of the uterus. Filar joint will be there only, the pars flaccida. What are the features of the retracted TM? One is the distorted cone of light, characterized. Prominent malleolar folds. Not only anterior, both the anterior and posterior malleolar folds are prominent. Third is foreshortening of the handle of the malleus. And then the mobility will be restricted. How to check the mobility? Already candidate answered. Siegel's pneumatics. So what is central perforation? Define central perforation.
It is a perforation in past tense or surrounded by past tense.
Good. Can you tell me the types of central perforation? Types of central perforation. How will you classify the central perforation?
Small central perforation, moderate, subtotal, total perforation.
What is the difference between subtotal and total perforation? If the annulus is present, then it becomes a subtotal. Even if the annulus is destroyed, it becomes a total perforation. Okay. So then you can classify the perforation based on the quadrants. How will you divide the quadrant to imaginary lines? So what because you can go and draw diagram there. Okay. So two imaginary lines is drawn. One is a vertical line along the handle of the malleus. Horizontal level of the umbo. Now how many quadrants you have got now?
4 quadrants.
What are the quadrants?
Anterosuperior quadrant, anteroinferior, posterior and posterior-inferior.
So you can tell the perforation based on these quadrants. Whether this perforation is occupying 1 quadrant or 2 quadrants or 3 quadrants or 4 quadrants. How do you differentiate the right TM from left TM? So right na 1 o'clock position, left na 11 o'clock. How will you test the hearing? What's the name? What's your name? Charlie. How will you assess the hearing level of the patient? Rennie's test? Silver's test? So, for doing the beautiful test, what you need? Frequency? Why 512? Is the speed? So, our normal speed frequency is 500 to 2000. So that's the reason why you are choosing 512. Okay. If you choose 256, 128, it more vibration of the market. You can also choose 1024 choose. So you can choose either 512 or 1024. Tell me how to do the Rennie's test. Keeping the base of the vehicle over the mastoid. Ask the patient whether he hears. When he stops hearing, he has to raise the hand or give a signal to us. As soon as he stops hearing, keep the hearing fork in front of the sternal canal. If he hears, it is air conduction is better than more clear. Better. Air conduction is better than bone conduction. Rennie is positive. Bone conduction is better than air conduction. Rennie is negative. In modified Rennie is what you said. You compare. But you can't wait till it stops. You try 24, keep it over there, and all the patient observe that how he can hear clearly. Quickly keep in front of external, all the patient how he hears now, which is audible more. Normally, the sound produced when we keep in front of the external is better than the sound expressed the patient when we keep over the master process. That is the comparing. That is called as modified Rennie's. So, in conductive hearing loss, Rennie's test will be negative. What is low positive Rennie? Sensory neural hearing loss. This is about Rennie's test. Next is Weber's test. Anywhere in the midline. Ask the patient tell which side is getting the sound. Okay.
If it is laterals to the affected nerves, it is directly area. If it is laterals to the materials, means the patient is sensitive to the.
If it is here in the center,
outside it's equal na revolution.
The sound is heard equally in both ears, or it is heard centrally, na, it becomes normal. If it is lateralized to one ear, na, then there is some problem. If it is lateralized to the same ear, that is the CSOM, na, then it is a conducting hearing loss. If it is lateralized to the opposite ear, na, then we are dealing with the CSOM with the sensory neural hearing loss. Next is
Absolute bone conduction test.
okay.
Just in this case, we are comparing examiner's bone conduction and the patient's bone conduction. Here we are
Assuming
that the
examiner is having a normal hearing.
Including the external organ.
That's important. That's the reason why it's called as absolute. So you set the tuning fork in the vibration, keep it over the metal process, at the same time upload the extraordinar by pressing the tragus. Or the patient to give a signal as soon as he stops hearing. As soon as he stops hearing, shift the same tuning fork to the same side of the examiner with the extraordinar post. The patient is right side parkrona, examiner to right side. Okay. And the exam also should upload the extraordinar. Now, if the examiner hears what it indicates, if the examiner doesn't hear what it indicates. Absolute confirmation, only two results are there. One is whether it is reduced or not reduced. If it is reduced, what it indicates?
The patient has sensory neural loss and it is reduced.
Not reduced, it's normal.
Normal.
அங்கே ஈக்குவல் அதான் சொல்லக்கூடாது. Whether reduced or not reduced. Because some example ask you to demonstrate before them. Tell me about the fistula test.
In fistula test, the pressure change should be.
How many methods of doing fistula test? Two methods. Alternatively, pressing and releasing the tragus and the extraordinar. You are building up the positive and negative pressure.
Another one is single step.
Yeah, single system. What will happen by doing all these things? In a normal person, what will happen? Nothing will happen.
No changes will happen, sir. In case of any fistula in the labyrinth.
Suppose by doing this, patient is getting nystagmus and vertigo. What indicates? There is an abnormal communication between the middle ear and the inner ear. That is positive fistula test, negative fistula test. Okay. What is false positive fistula test? False positive. Yes. Conditions causing false positive fistula test. One is next is syphilis, congenital syphilis. Meanies la yeah false positive varudhu. What is the main pathology in meanies is there can be overproduction of adrenaline for lesser absorption of adrenaline. Mottham enna agudhu, there is a endolymphatic hydrops. There membranous labyrinth is bulging, enlarged. The fistula test. Okay. You are increasing the pressure in the middle ear. Okay. That is making the movement of the footplate of stapes. If the membranous labyrinth is bulging, what will happen? The usual traveling distance of the footplate will go and touch the bulging membranous labyrinth. Okay. That is the saccule is touching. Saccule by touch பண்றது என்ன ஆகும்? Automatically patient will experience the giddiness. So that is the reason you should tell. Because of the bulging saccule, which is disturbed or stimulated by the footplate of stapes. Normally that will not happen because saccule வந்து அவரோட bulge இருக்கு. So what is the cause in the syphilis? Congenital syphilis.
Due to hypermobility of
Hypermobility of the
stapes
he is giving the answer because the lax annular ligaments. The supinator stapes is attached with the bony vestibule by the annular ligaments. This annular ligament is very lax in the condylar surface, so it will be traveling a long duration, and so it will be stimulating the normally located circuit. Whatever false negative fistula, there is a fistula, but namakku theriyilla. Which condition can occur? In the case of extensive cholecystoma, which is preventing the pressure build-up to be transmitted to the fistula area. Next thing is dead labyrinth. Labyrinth dead ஆயிடுச்சு, அப்புறம் fistula இருந்து என்ன போய் பண்ண போகுது? There will be some facial nerve test. The prognostic test for facial nerve. You are telling the facial nerve is normal. எதை வச்சு சொல்ற facial nerve normal? In other words, what's your name? சரி, பக்கத்துல இருக்கவனுக்கு facial nerve palsy இருந்துச்சுன்னா எப்படி இருக்கும்? பக்கத்து கேண்டிடேட் அவனுக்கு facial nerve palsy இருந்தா இருந்தா எப்படி இருக்கும்? If the person is having a facial nerve palsy, what will be the appearance? Asymmetry. Wells phenomenon is a rolling upward of the eyeball. Okay, அடுத்தது angle of mouth deviation to the which side? Angle of deviation. Angle of mouth deviation. Opposite side. E சொல்றா என்ன பண்ணுவானா இந்த சைடு affected side அப்படியே இருக்கும். இந்த சைடு வந்து you can see the figure. Okay. These are the features you can see in a facial nerve palsy. So facial nerve function normal நீங்க முடிப்பீங்க எக்ஸாம்ல. எதை வச்சு நார்மல் கேட்டா என்ன சொல்றீங்க? அதெல்லாம் நீ சொல்லணும். I have examined the face of the patient. He is able to raise the wrinkles of the forehead, able to close the eyes. He can tell I ask the patient till E is able to the angle of mouth is LT. If there is deviation of angle of mouth, if there is Bell's phenomenon, or patient is not able to raise the wrinkles of the forehead, then patient of palsy is there. Okay. Now you should tell what is the UMN palsy and the element palsy. Upper motor neuron palsy, lower motor neuron palsy. Which will be spared in the upper motor neuron palsy. The lower motor neuron, the entire face is affected. In the upper motor neuron, the forehead is spared because it has got a cross innervation or bilateral innervation. There will be some topognostic test for facial nerve palsy. Yeah, Skidmore test. Good. Now you should know about the course of the facial nerve within the temporal bone. Can tell me the course of the facial nerve? Intertemporal course. எப்படி? எந்த இடத்துல என்ட்ரு ஆகுது, எந்த எக்ஸிட் ஆகுது? Good. Internal auditory meatus, it enters. So that is the meatal component. Okay. Next, labyrinthine component. Okay. அடுத்தது first genome. Okay. Next, the horizontal or the tympanic segment. second genome. அப்புறம் vertical of the mastoid cells. ஓகேவா? எப்படி வெளியே வருது? It is coming out by which? நானே பதில் சொல்லிருக்கேமா? Tell me the branches of the facial, the intratemporal course. The other candidates can help. Nerve to stability is good. Nerve to stability is வந்து எந்த செக்மெண்ட்ல போகுது? Vertical or the mastoid segments of. So nerve to stability, okay. Heart dependent, good.
Branches to pterygoparotid.
First genome ஏதாவது வருதா வெளியே வருதா? GSPN. அதுக்கு தான் வந்து ஸ்கில்மஸ் டெஸ்ட் வந்துருது. Then for the nerve to stability என்னது? We are doing the acoustic reflex test. Then heart dependent. So you can know facial function na இவ்வளோ விஷயம் இருக்குது. What is 3-finger test? Just examination is really important. Landmark for the equivalence triangle, which is in turn the landmark for the macroangle. So for the macroangle, you have to press over the single marker. Then another finger.
Middle finger on the posterior border of mastoid and the index finger on the mastoid.
Mastoid? Okay. The positive one, it indicates mastoiditis. What is Grady-Negro syndrome? Diplopia because of the which nerve involved? Discharge because of the mastoid cells are infected, especially the ventrositis. Because of fifth nerve involved. So Grady-Negro syndrome, it indicates here well pneumatized mastoid. The pneumatization is there till the fetus happens. So fetus is there. So you have to clear the disease till the fetus happens.